As far as opening your own ASC OBL, you do have to have some patience.
Hey guys, it is Justin, and I am here with the OBL and ASC Marketing Blueprint, and I'm on with, as always, our VP of Sales, Rachel, and Dr. Pollock out of Knoxville, Tennessee. Dr. Pollock, tell us about your practice and how long you've been in the IR space.
Sure. So I've been in the IR space for 23 years. I am a vascular surgeon, but in the interventional space since 2003. We opened our first outpatient center in 2009 and then 2011. And then I started Apex Vascular in 2020. And so our goal with Apex Vascular was to provide an ambulatory surgical setting for vascular patients. And it was to provide it in a more kind, caring, family style environment where patients could heal well, be successful, and have a nice experience. So we started our practice in 2022. We're almost 3 years into our new practice. We have converted over to the ASC. We got our accreditation completed 2 months ago. So We're now accredited ambulatory surgery center. So we have the ability to function in both realms. We only have the one OBL and ASC. It's in one location, but we have, 7 satellite clinics.
You've made our team do a little bit of work in learning the southern region.
Yes.
They've definitely got a cheat sheet for you guys.
Once a week, every other week. And the goal is to bring our care to the patient, so to get it closer to the patient. So, they don't have to travel to see us, travel for their post-procedure visit. Now, they'll have to come to the ambulatory surgery center for their visit, but it's to get the patient care closer to the patient.
So tell me, how did you kind of make that shift? I mean, doing the cardiovascular surgeon into the IR space, and now you're doing a lot more of the embolizations. How did that progression happen?
Microembolization stuff has really taken off. I became interested in it, and my story's a little bit, slightly, probably similar. We were looking at uterine fibroid embolization, and we were looking at to see if we were interested in doing uterine fibroid embolization. And I went to the OEIS conference meeting and heard you guys talk. And as I was listening to it, I was thinking to myself, my patient population is a typical vascular patient population, older. And the one that jumped out at me that was more natural to my patient population was knee microembolization. So
just to be clear, you weren't doing embolizations till we met last year at OEIS.
That is correct. We were doing no embolizations until we met at OEIS.
So talk to me now. So you guys have shifted your practice. Now you're doing, social media lead generation with us, going direct to the patients. What is the contrast in your traditional referral patients that you get versus the people that are coming in from social media? What are you seeing as like a different experience?
Well, they're definitely more educated. With the social media apparatus, when they come to see us, they're already educated. They've already read the research. They've already looked at the stuff online. They've typically looked at our website. So we have on our website, we have literature supporting this, how the procedure is done, what to expect, what your visit's going to expect. So when they come to us, they're prepared. And like we were talking about earlier, it's a pretty seamless progression once they see us, because they already kind of know what they're looking for, what they want. They've searched us, they've researched us. So there's a lot of the questions already.
And just a nugget for everyone here, because our team does do the bookings for Dr. Pollock's social media. If you have a link or something on your website that explains the procedure, sending that to the patient after they've booked, the chance of that person going to procedure, and we see this across clinics, because we have some clinics that have this material and some that don't, is much, much higher. And the social media generation, they're on their phones. They want to look at it, send them something versus someone coming in. And again, you guys have all been with referrals. You got a knee pain referral, if you're lucky enough to get a knee pain referral, but you get a referral from someone else, and it's just, well, what do we do next? And they have to go home and talk about it and think about it. So no, you guys are doing a great job on that. What is your favorite patient story? I'm sure everyone's got that one that somebody came in and you saw them change their life and have an amazing outcome.
Yeah, so I had a patient come in our Crossville clinic that had a knee replacement. And when we early on started this, the process in knee, we weren't sure exactly how post-knee replacements were going to fit into our practice, but did some research, did some reading, looked at some of the studies, and saw that there was a nice indication for knee replacement. So we had a lady that was I would say about 2 years out from a knee replacement and was miserable. She still had pain, she still had swelling, still had stiffness, and she still had terrible quality of life. And so she came to me, saw us in the clinic. I said, well, I think we can help. And so we did, and we embolized 3 vessels on her, and it's dramatically changed her life. She came back to me, she said her pain is gone, her stiffness is gone, and literally she is back to exercising. She was trying to lose weight, but she couldn't lose weight because she couldn't exercise, and she's super happy. So I would say that's probably my favorite story, although there's been a lot of really good stories because these patients are miserable, and either they're been told they got to have a knee replacement, or they've had a knee replacement, but they're miserable. They've tried injections, they've tried therapy, and we've been able to treat them, and they're pain-free.
I love that you're doing the post-TKR. That was something that, we've been in the GAE space for a few years, and that was a kind of a, could we do it? Maybe, but
yes,
there's such a market for that.
Yes, and it's really been successful. We've probably done, I would say 5 or 6 now. And I've got a couple more planned.
So talk to me now that you guys have got this process and you've built in the GAE direct to patient, you're going the heel or the plantar fascia direct to patient. How has that shifted the way that you run clinic operations? Because you kind of have funnel, a dial now of turning on the flow. Has it changed the way you handle like mid-levels, patient flow, any of those kind of things?
We actually still kind of function the same way. What we've just added double booking different time slots because these patients typically, like I said, are well-educated, well-informed. So they don't take quite as long. I'd say probably 60, 70% of them are seen by our mid-level. We are adding, as we mentioned, a second mid-level to help with the volume. So we're going to add a second mid-level to help with that. But no, it's a very smooth process. But it really, as far as our clinic organization, it's really pretty much the same. We don't have special slots for them as far as timing, but we do have special slots for them because you can do more in a small amount of time.
And then when it comes to that, because obviously you're hopefully doing more procedures, have you had to plan for growth and staffing in the OBL or ASC as you're doing more procedures and more embolizations?
What a great question. We are opening our second room on Tuesday. Woo. So, so when we built out our ambulatory surgery center, we had built a 2-room surgery center with plans for growth. January hit, we quickly realized we do not have the capacity to cover all these cases. So we are now going to open the second room on Tuesday of next month, the 1st, April, and we're going to run 2 full rooms full time.
That's awesome. Congratulations. Yeah. Talk to me on marketing. Obviously, we're handling the direct-to-patient on social media. Are you doing boots on the ground, traditional? Like, what other stuff are you doing in your area and region?
Yeah, so we do have a full-time marketer who does our direct marketing, that works really well for the vascular wound care, vascular surgical care, other vascular care. I would say we have brochures. He hands out. He educates some of the primary care providers, but it doesn't even compare to the direct patient marketing that you guys do.
From a business perspective, if you could go back and give yourself one piece of advice from when you first opened your OBL or ASC or whatever it was when you first opened, what would that be if you could go back in time to 2022?
As far as opening your own ASC OBL, you do have to have some patience. It doesn't happen overnight. The business comes overnight, but the nuances of billing, coding, IT work, all that takes a little bit of time to get a smooth operation. Finding your niche. I didn't know when we opened that we were going to really find a niche in micro-embolization because it doesn't happen overnight. It does take a little bit of time to get exactly where you want it to be. We're added plantar fasciitis, which we're seeing that grow rapidly, as we just talked about earlier. I think continuing to expand our micro-embolization for pain, shoulder, hip, and start in those fields. We are doing some pelvic congestion work. And I think that's where we'll concentrate in 2025.
Awesome. Well, Dr. Pollock, I appreciate you being on. Thank you so much, guys. You can check him out at apexvascular.com.
That is correct.
Make sure I have the right. Awesome. Wait, I appreciate you being on the podcast and keep changing lives out there. Thank you.
Thank you.